what is this? Do we use this anymore? So I always say, like I said, this is your house. You're supposed to know, if you come in my house, I can tell you where my blender is, the pieces over here, the pieces over there. My husband may not can find it, but I can tell you, right? Because I know where the stuff is. So you should be familiar with what's in your unit. And as a leader, you should know, or training your team under you to inspect your unit. Like, also, like when people come on your unit, you don't know, or they don't look familiar. To me, all that kind of goes together. We have to be more aware and to know what's going on where we live.
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome. It is Season 2 of the Transmission Control Podcast, and we're on today with Euriel Brown, Accreditation Manager for Emory University Hospital Midtown in Atlanta, Georgia. Today we talk about tracer chasers and how to make a tracer activity effective, sustainable, and to better prepare your team for your next accreditation survey. We'll be right back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollenbeek, Editor-in-Chief of Transmission Control, and we're joined today by Jill Holdsworth. How you doing, Jill?
Hey, I'm doing great. Glad to be back.
Yeah, we're excited for Season 2. Season 1, we talked about the orientation station and everything about being a new IP. This season, we're focusing on Citation Nation. So it's everything that's citable, everything survey prep, and we've got a great group of guests lined up for Season 2. So I'm pretty excited.
And this is going to be awesome. And I think it's really on a lot of people's minds as they're thinking about their next survey, whether it's Joint Commission, it's DMV, or CMS, the state comes in. There's so many different things that you can get cited for. So IPs everywhere are always thinking about what could they possibly find this time?
Yep, absolutely. And for our listeners, as you're going through this season, you're going to hear a lot of frontline and first-hand stories from people out there. And that's great for two reasons. One, you get to learn about what other people are doing. And then you get to learn that people out there are getting cited and that, it doesn't make you a bad IP if your facility gets a citation. So our first guest for Season 2 is Euriel Brown, Accreditation Manager for Emory University Hospital Midtown out there in Atlanta, Georgia. Euriel, how are you doing today?
Hey, Garrett and Jill. I'm doing well. Thanks for having me.
Yeah, absolutely.
We're happy to have you here, Euriel. And when we were looking for guests for this podcast, of course, my mind immediately went to you. I think I told you that when I asked you, and as you go through your background, I think everybody will understand a little bit more why you were my kind of first choice to come on to this season.
Well, I'll take that as a big honor, Jill. I think I appreciate you thinking of me like that. Thank you.
Why don't you go ahead and give us a little bit of your background, how you got into what you're doing and how you're so connected to the IP world?
Sure. Yeah. So probably in about 2011, I think in 2011, I lived in Dallas. I'm from Dallas, Texas, and I was in the infection prevention department. I worked as more of a system analyst, kind of more of an admin role. And I just was so closely with the data and the IPs. My director said, I think you should be an IP. And I was like, well, I think I should too. So I onboarded, I trained, and I think for about 7 years, up until about 2018, I was an infection prevention specialist at Children's Medical Center in Dallas. So it's about 500-bed pediatric hospital, one of the biggest in the state of Texas, and definitely the biggest in the North Texas region. Learned a lot. Then I met my husband, who's actually from Atlanta, and moved to Atlanta in the summer of 2018 and decided to kind of pivot into accreditation. So I applied Emory Midtown, and it's been a good fit ever since. I've been in the role for 7 years. Midtown has grown tremendously since I've been here, and I still have close relationships with our IP team. We're both under the Office of Quality, and I think me and Jill, we work really well together, her and her team, and we, having the IP background, I think also kind of helps foster that relationship.
I think that's true because you're kind of coming from the same language and you know what the priorities are, you know how to approach things. And one really neat element that both accreditation and IP have in common is doing these tracers. And so, Euriel, can you give us kind of a broad overview of what a tracer activity is?
Absolutely, Garrett. A tracer, to me, in the simplest terms, a tracer is just basically being in the GIMBA, being in the unit where the work is taking place, basically watching people do their job and verifying that they are compliant or not compliant with your organization's policies and procedures. And also, of course, with your regulatory bodies.
I have something to ask you to clarify if you would, because I just had this conversation with somebody this past week. Can you kind of tell us the difference between doing an actual tracer and an IP just doing like their daily rounding in units where they're kind of going every day, but then there's maybe a day that you do the actual tracer. So what's the difference between the two?
I think usually a tracer is more a formal plan of attack. We do use Joint Commission Resources tracer system in AMP, and it does give us a more formal question itinerary agenda of what we're looking for that particular day. Maybe it's an outbreak, or maybe we had some patient safety incidents and we're trying to see a process. So I believe tracers kind of give you more of a detailed focus on what you're looking for. And when you're usually doing rounding, you're just usually just trying to see what you see that day on the unit, your snapshot of the day.
Okay. So you're targeting what you're looking for in the tracer specific to either like you're preparing for an audit or something happened in the facility and now you're trying to run down other things that may be happening around that process.
Absolutely.
Now, have you ever seen anything in a tracer activity that surprised you or kind of took you off guard? I think people like hearing those stories.
Yeah, I have. I mean, I've been on several surveys. I've been in several tracers. Like, you name it, I've probably seen it. I think the biggest thing you tend to see is when processes you no longer do, or you find evidence of that old process, and it tends to get you, I hate to say in trouble, but it raises a red flag. Like one survey in our ED, we found some old equipment that the staff did not even know how to use. Pieces were expired, but it was still a part of the unit and everybody kind of treated it like a coat hanger. But just in case that procedure needed to occur, maybe we had somebody rotating in, they might have grabbed it and used it. But it was not a procedure that we normally do. And so it just kind of raised a red flag, like kind of why is it still here? And we don't use this. We don't do this process anymore. So usually it's stuff like that, like expired stuff that outdated, that are not even part of our service anymore. Just people not closing the loop on getting rid of certain equipment or certain supplies.
But that's what the surveyors will find.
Exactly.
When they come, they don't care if it's something that you stopped doing 3 years ago or 3 days ago or that you use now. If it's there, it's expired, and people don't know how to use it or clean it, that's what they're going to find. It's like they're a magnet for those old processes that we forgot about. And that's such a good point. Do you have any practical advice for people, and kind of just thinking about an ED where there's probably a million different things sitting around and processes, thinking about a place that's busy like that? How can you go about looking for those types of things, or even in an ICU? I mean, really any unit where you're just trying to make sure that the things that are actually there are the things you need.
I think there is a such thing as a downtime. I know it sounds foreign at our busy hospital, but there are some times when you do have downtime, and I think leaders should make sure they assign roles to everybody, because I always say, this is your house. Your unit is your house. You live here. I do not. So you should be doing some sort of rounding at some point of the day, the week, just putting your eyes on every piece of your unit. And if you can't do it all, which I don't expect you to, you're a person who comes in the morning. They did half of it. You did the other half. There should be a conversation, communication of, well, I found this. What is this? Do we use this anymore? So I always say, this is your house. You're supposed to know, if you come in my house, I can tell you where my blender is, the pieces over here, the pieces over there. My husband may not can find it, but I can tell you, right? Because I know where the stuff is. So you should be familiar with what's in your unit. And as a leader, you should know, or training your team under you to inspect your unit. Also, when people come on your unit, you don't know, or they don't look familiar. To me, all that kind of goes together. We have to be more aware to know what's going on where we live.
Yeah, I think that's a great parallel too, because when you're looking for something specific, I had a boss at one of my first jobs, and in a feed store, everything's dusty. So he'd say, all right, I'm going to write your name in some dust somewhere in the store. And if you don't find it by the end of the day, you're fired. So I never got fired, thankfully. I didn't find my name all the time, but I knew what I was looking for. And I think that's one of the values of the tracer, is it gives staff something to look for, to say, this month we're going to look for expired supplies, or this month we're going to look for equipment we don't use anymore. And there is a standard in the Joint Commission standards that we have to know what equipment we have in house. We have to have an inventory, and it has to be in good working order. We can't just have stuff that doesn't work laying around.
One thing that Euriel said that really made me think is there could be a lot of different people doing that rounding. And, it could be the leader of the unit, but like she said, they could delegate it out to somebody. And do they know what they're looking for? And so I think that's super important. Even if you say each month you're looking for something, if you're having an admin or a secretary do it, are they trained to look for what they need to look for? Are you actually opening up cabinets, or are you saying you're rounding by just walking around and looking at the ceiling tiles? So at some point there has to be some sort of tracer rounding training, depending on who you are or what your role is or how much knowledge you have.
No, Jill, I totally 110% agree with you. And even at Midtown, what I've started doing is I have a project with our department assistants for our nursing units. And when they get assigned to basically round the unit, I've met with each one of them individually and literally went through all 20 questions of the tracer just so and walked the unit with them that they're assigned to lay eyes on the items. This is what this means, and the why behind why we have to look for it. Because a lot of times people are just checking the box. If they don't understand the why do we look for dirty ceiling tiles? It's not because, of course, aesthetically, it's not appeasing, but what's behind that ceiling tile, and what's the damage that could do to anybody inhaling or leaking or anything. So showing them and telling them the why is really I'm a big champion for that. So I totally agree with you, Jill. So as they onboard more and more, and we do refresh it, because let's be honest, their directors probably don't have time to do that, which is fine. So I can make time to do that. So I agree. You have to show people what they're looking for and the why, and you'll be super surprised of how it opens their mind and eyes to different stuff on their unit that you didn't even probably have on a tracer. So they call me and email me all the time, like, okay, I saw this. What does this mean? So really got to show.
Yeah, I think the ceiling tiles is such a great example, because I even see facilities just replace it and be like, man, it's fine now. They'll stop bothering me for a while until it stains again. But there's a reason it's stained, and there's a reason that we worry about it. So that's such a great kind of connection to why. And because I think the staff on the unit are the same thing too. Like, oh, infection control might come around and find the stained ceiling tile. And so really understanding that, hey, there might be mold up there. There might be a continuous leak up there, and then they're like, oh man, that's actually kind of bad. So better tell somebody.
Right. And as much as it rains in Atlanta, that's another thing I lead with the girls. I'm like, especially after it rains, make sure you do a sweep, because it's going to be a stained ceiling tile shortly after.
That's a great approach too, in the training that you engage with the staff before you go out and do a tracer. I don't hear that happen all the time. And so I think that's a great takeaway for the audience to say, I'm going to go and do some training before we go to the tracer. So we all feel prepared. We all feel confident in what we're looking for, and it can be a good outcome for the site. Now, with that tracer process, you're working closely with infection prevention. And I want to ask, who takes the lead when you're working with accreditation on, let's say, a tracer? Well, what's a common tracer that you may do with infection prevention?
Infection prevention has a lot of tracers. Let's just start there.
Not surprised.
Let's just start there. Not only does IP have tracers for obviously the standards that we are required to follow, but also processes and process improvement that we have identified at our organization specifically. So the gamut of tracers is huge, because not only are they doing what we're required, but our IP team takes it to another level of, we've identified an issue and now we're creating a tracer and we're going to watch it. The tracer evolved into a bigger process improvement project.
I think the models that you'll see is there's different rounding. Like IP will probably do their own rounding. We have a safety team also that does rounding. Accreditation can do their own rounding. And so I think that we'll find, as we talk to more IPs, that there's kind of like a varying level of involvement in all of these rounds. But I think as IPs, we feel like we have to be on all the rounds, because we always feel like no one can see it better than we can. And so I think that's also where it becomes hard for IPs, across the country, that how are we efficient with our rounds? How do we make sure we're not sending out too many reports and getting people to respond? And I don't know if you have any comments on that or advice, Euriel, but the most frustrating thing to me is when I spend the time to do a tracer, I send out their report, I tell them what their opportunities are, and then it's radio silence after that. I hear nothing, and I don't know if they don't care, if they didn't read it, or if they just are ignoring me.
Jill, that is probably the number one issue in accreditation is, I call it the hamster wheel. We're out rounding, we find, we report, we go back, it's still the same, and we're just spinning our wheels. It's the hamster wheel. And you get frustrated because it's wrong and it needs to be fixed, but they don't report to you. So the biggest thing that I do, as you're well aware of, is, either I escalate to my leader or I escalate it over their leader. I'll take it a step further and let usually their specialty director know. And I've also been known to let our CNO know also on said communication. Sometime it works, sometime it doesn't. As you know, pictures speak louder than words. So we always take a lot of pictures. I literally was on a unit last week. I found some supplies expired from 2023 in a very high-risk area. So I said, hey, this cannot happen, right? So it's the hamster wheel. And I tell all other fellow accreditation managers too, especially new ones, that don't get frustrated, because as long as you follow your steps, we got to keep doing it. We got to keep rounding. We got to keep reporting, and we got to keep escalating, but that's just unfortunately the nature of the beast. And usually they don't believe you until a surveyor shows up and they identify those exact same issues. And I'm always like, I never say I told you so, but I'm always thinking it.
I think that's real though. I mean, because we do a lot of work to kind of raise the red flag to say this is an issue, or it could really turn into an issue. I think the stained ceiling tiles is a really good example because people will say the why behind it is not because a surveyor is going to find it. There's a real patient harm risk. And, as IP, we're kind of responsible for being aware of the standards, aware of the research behind the standards, and being able to say, well, if you have stained ceiling tiles, you might have water intrusion, you might have mold issues, and that's kind of on us to lay that story out. But I want to ask Euriel, where you've found that storytelling or the storytelling from the tracer to drive some good positive change.
We had an issue that a specimen was not lost. It was mislabeled. I'll start there. And it was going to be reinserted into the patient. We couldn't identify the specimen. It was 3 pieces and we couldn't identify who it belonged to, right? So a surgery had to be postponed and it just caused, unfortunately, an unnecessary cause and effect. We fixed the issue in real time. We changed the entire process. So we had to essentially follow our OR people, show us the process. So kind of got in the gimbal with them. And so now you show me the process. They fixed it. And once they did, we created a tracer to kind of shadow them essentially to verify that it was addressed and correct. So that's probably it was a really, really big case. It had a lot of media coverage, unfortunately. So having the tracer allowed us to go and follow them to make sure that they were following our corrective actions that had been identified to correct the issue. Needless to say, at the new process, we also created a brand new process. We had to order new freezers, retrain staff. So it was like a month-long process, really involvement to correct the issue originally. And having the tracer, having our set questions, because now we know the process, we know how you're supposed to document certain things in Epic and where certain things are supposed to be placed, how our freezers are monitored. So the tracer outlined all that to ensure that now we're rocking and rolling so we won't have any more of those incidents where we are not able to identify a patient's specimens.
And I think what Euriel's describing, where we made our own tracer, is so important, whether you have an electronic system or you don't, because we didn't always have an electronic system, and I certainly haven't in other jobs. But taking a process and making your own tracer can be just as easy. You don't have to have a preset tracer that somebody gives you. People are always asking me, can you send me your SPD tracer? Can you send me this or this? And I tell people to sometimes just do it in reverse. Go round, see what you see, and start making your tracers yourself like that. If you're seeing stained ceiling tiles, if you're seeing holes in the wall, bad floors, things like that, start putting that on your tracer, whether it's in an Excel document or some sort of program. And if you start going on these tracers, and I always have an other section in my tracers, and if you start seeing that the same other thing is always showing up, then you add it as a question. So I think you have to kind of evolve your tracers too to make sure that it's inclusive of what you need to see.
Yeah, it's essentially a living document. It's going to get, as things are tightened up and the process works, some things may fall off, and then, other things may hop on there. I think that's a really good reminder. And that kind of speaks to the sustained model. So, Euriel, once a new process has been put in place, what's accreditation's role in making sure the process stays the way it should be? And then how can infection prevention help support that?
Well, what accreditation likes to do is we do work with our patient safety managers also. So if there's an incident, our team will put in what we like to call a SAFE report, or our version of incident report. So we also track those if said issue is getting reported by the staff. Also, we'll kind of put it on a timer. So like now, originally the corrective action was that we were going to audit you twice a week or every other week. Then once the process is going well and we're not seeing any issues, we try to give you a little space. Joint Commission, our state surveyors, they never want you to not audit anymore. You can never have zero or once we hit 100%, we're done. That's not realistic to say that we stop auditing, because we never stop auditing. We might not go as frequently, but we're always going to tap in and audit. So I haven't been in January. I'll go in February, especially depending on how high risk of that issue is. And accreditation leans on infection control also to identify not even that particular issue, but if they see another issue that maybe stemmed from that issue, hey, those specimens were lost and not labeled, but did you see over here, these were not either. And that was a totally different surgical procedure. So we lean on them to kind of also be another set of eyes and ears when they're out on rounding, because unfortunately tracers and rounding are literally just a snapshot. It's like taking a culture of a sample of urine that day. It's literally just a snapshot of that day and time. So we rely on them heavily to say, hey, I saw this. What do you think about this? What's the risk level of this? So we're leaning heavy on them.
And I think that's a great point and advice for anybody listening. How often do you include accreditation or your regulatory person? And it could be a different model anywhere that you're working. Like we happen to all work under quality. I've had different models in other places, but the way that at least we have done this at our facility is Euriel and her counterpart are included in every report that we do on rounds, everything that we're reporting that could have a regulatory issue. And my team will always say, hey, do you think we should include Euriel on this? Because I think this is a regulatory requirement. So we're always communicating with accreditation. And I think that you can't over communicate as an IP to accreditation, even if you're just copying them on your Joint Commission rounding reports or whatever, because we all have to be aware of what each of us are seeing. And as IPs, we're all out there every single day, and we have a really good chance of seeing something in one of those snapshots that we're on the units, because we are out there so much. So my advice would be to include your regulatory person in like everything.
Yeah, we don't like to be surprised either.
That's great advice, though, because it gives you another bite at the apple where you can go and say, hey, accreditation saw this last month. I'm seeing it this month. When we're rounding on our tracer, we also observed it. So it really gives you another opportunity there. Now, Euriel, as we wrap up today, what are some good takeaways or go and do's that our IPs can do to make their survey readiness better or to improve their tracers?
Some go and do's that I always say is go on your unit. You don't know what's going on unless you're out there doing your rounds. Piggyback what Jill said, make the tracer your own. Yes, the resources we use, they do have a library of questions, but tailor it to your facility, to your organization's needs, and to your needs. If you had a tracer and it had 40 questions, that's not realistic. So, reduce the amount of questions so that you can hit it and you understand what you're looking at and you don't feel like it's a task, because I feel like you feel like it's a task, then you don't want to do it and you won't do it and you'll have to do it. So, make it your own and make it tailored to you. As long as you're out there and you are recording what you see, there's really no wrong answer or no wrong way to do it. Like Nike, just do it. Just get out there and do it.
That's awesome.
It really is. That's half the battle, is just getting out there and doing it. And I think that point of like a 40 question long tracer, oh man, that's tough.
Yeah.
And no one wants to get a report that long either.
Nobody's going to read it.
They're not
and even surveyors don't, when they're out on tracers, they've done it so much that they don't even have the questions. They have all the questions memorized. Honestly, when I go out on units, depending on what I'm looking for that particular day, I don't take a paper either. I just I know what I see. Even if I'm like, wasn't looking for something, I'm like, okay, that's not right.
Yeah, absolutely. I say that to people all the time in IP, like, don't go around with your clipboard. That's like the biggest stereotype that that we can have. I usually don't even take anything at all with me so that I can be like, I don't even have paper. I'm not even writing anything down. I just really want to observe. But you're keeping track in your mind, or you like make yourself a quick note on your phone.
Yeah, that's also the biggest way, any IP out there, for people to run away from you. Like I come on,
Yes,
people
exactly.
will run away from you as soon as you come on those units when they see those clipboards.
That is 100% true. We're going to miss things, right? If we can't see it in real time and see what's going on, we run the risk. So, Euriel, I want to thank you so much for giving us a great set of information on how to do a tracer successfully and how to train staff so that we're ready. Thank you for keeping our patients safe. We appreciate it.
Thank you. And thank you again for having me. This was fun, guys.
Well, Jill, that was awesome for two reasons. One, we got to meet one of your coworkers. And two, Euriel is just a wealth of knowledge. We love it when people have an IP background, and then her moving over to the accreditation side of things just kind of gives you both sides of the hill. One thing that I really liked in that interview was the part about training people on the tracer. And I don't know how often we do that, but it's really helpful to do all that kind of legwork ahead of time. And then once somebody has the tracer in hand, they can go out and really feel prepared to make an impact.
Yeah, that's such a great point. I feel like after this episode, people are going to be super jealous of my accreditation manager, but it is such a great thing for us to have an IP as in charge of regulatory, because having someone with that knowledge has been so helpful for us. And especially when we go on our own tracers with Euriel there with us, it's just made it that much more optimized. And I really liked how we talked about including your regulatory person in communication and really bringing them in on IP tracers, regardless of their background, because we can all use that support. And if you don't already have that kind of a relationship, this is the perfect place to start. And as we wrap up this episode, don't forget that infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.